Good afternoon. Welcome to everyone joining us this Monday afternoon for a session on the rollout of naloxone by the Western Australia Police Force. My name is Jake Dizard, and I'm the Senior Research Officer here at Penington Institute. I'd like to start by acknowledging the traditional owners of the unceded land where I currently am, the Wurundjeri people of the Kulin Nation here in Melbourne. I acknowledge elders past, present, and future, and would like to welcome any First Nations people we have in the audience today. Penington Institute has been very involved in the efforts to encourage and facilitate widespread access to naloxone across Australia, including helping to develop the model for the Commonwealth's take-home naloxone program throughout Australia, as well as training frontline services in providing naloxone. We have an excellent set of panelists with us today to discuss the distribution and use of naloxone by a particularly crucial frontline agency, the police. So members of this group have graciously agreed to join us today from Perth to discuss the naloxone rollout by the Western Australia Police Force. So I will introduce our panelists in order of their remarks. First, we have Professor Simon Lenton, who is director of the National Drug Research Institute, where he has worked since 1993. So happy multi-decade anniversary to you, Simon. In addition, he works part-time as a clinical psychologist in private practice. And Simon's research interests include bridging the gap between drug policy research and drug policy practice, illicit drug use and harm reduction, and the impact of legislative options for drugs. His current research program includes evaluations of take-home naloxone programs in Australia and an international collaborative web survey of small-time cannabis cultivators in 18 countries. He has published very widely on drugs, health, and the law, and has provided advice to a range of government and private organizations, both in Australia and internationally, on evidence-based drug policy and other drug issues. And Simon's going to provide some background, some broad background on the use of naloxone as a life-saving intervention for opioid overdose today. He'll be followed by Dr. Seraina Agramunt. Dr. Seraina Agramunt is a research associate at the National Drug Research Institute. She's conducted research and assessed the effectiveness of several naloxone programs in the community, which have been instrumental in expanding these programs and advocating for the use of naloxone. She also coordinates the Western Australia arm of the Illicit Drug Reporting System, an ongoing and very important national illicit drug monitoring system that analyzes the use, market features, harms, and trends associated with major illicit drugs. So Seraina will give a presentation on the evaluation that her and Simon's team conducted on the police naloxone pilot in Western Australia. And then finally, we have Lucas Ride. Lucas has been with the Western Australia Police Force for 12 years and is currently strategic advisor responsible for illicit drug policy and strategy. Along with serving as the Western Australia Police Force representative on a variety of state and Commonwealth interagency groups relating to illicit drugs, he is involved with the development and implementation of a range of innovative programs within the agency, including the Western Australia Police Force Naloxone Initiative. Prior to joining Western Australia Police, Lucas was the managing director of a management consultancy firm specializing in policy and program evaluation of government initiatives in the fields of drug and alcohol, justice, and health. And Lucas will provide us with a police perspective on the implementation of the program so far. Just one quick housekeeping note before we get to our panelists. We expect that the panelist presentations and comments will take the next 35 minutes or so, but if anyone has any questions at any point, please drop them into the Q&A box at any time during the webinar, and we'll try to pick up as many as possible during the Q&A period that will occupy the last 15 to 20 minutes or so of the webinar. And with that, Simon, the floor is yours.
Thanks, Jake. I'm joining you from Wajak Noongar Budja, and I'd like to pay respects to elders past, present, and emerging, acknowledging these lands have never been ceded and paying respects to all First Nations people who might be online. So I'm going to give you a very brief whip through where we've come with take-home naloxone. And it really began in the 1990s when in Italy in 1995, they had an opioid overdose crisis and made naloxone available through pharmacies. And soon after that, in this country and many other countries, a number of us started calling for more widespread availability of this life-saving medicine, which had 3 decades of use in medicine and pre-hospital care, extremely safe medicine that has one function, which is just to reverse the effects of opioids in the short term. But then what happened was in 2000, we saw the heroin drought or the heroin shortage hit, and thankfully we saw overdoses drop substantially, but obviously calls for more widespread availability of naloxone really got lost amid concerns about rising methamphetamine use in Australia, which was completely understandable. But then in 2000 we saw an increase in opioid overdoses. They hadn't dropped away entirely, but the line started trending up, and a number of us said, hey, maybe it's time to be starting to look at more widespread availability of naloxone in Australia. And that was opposed by a number of powerful voices. But in 2012, the peer-based advocacy and harm reduction group in the ACT, CARMA, ran a trial of making it available to their members and more widely. And then soon after, it was very closely followed by similar programs in a number of other states. The evaluations of those programs showed that it had improved knowledge about overdoses and improved responses, that people knew how to use it, and also that they had saved a number of lives, which was fantastic to hear. But scale up was an issue. And then in 2014, the WHO endorsed making naloxone more widely available to prevent and manage overdose deaths or overdoses and overdose deaths. And then in 2016, the Therapeutic Goods Administration in this country, with a great deal of support behind the scenes, including the evaluations, the data from those early evaluations, and some strong advocacy from a whole bunch of people, including Penington and a whole range of other people across the country, resulted in it being rescheduled. So there was a dual listing, so it was available both across the counter and also by prescription. And then in 2019 to 21, we saw the federal PBS subsidised take-home naloxone pilot in South Australia, New South Wales and WA, where naloxone was provided free of cost. And then in November 2019, we saw it listed on the PBS, and we also saw Nixoid, the intranasal form, become available in this country, which was a real game changer. And then in 2022, the University of Queensland evaluation of that national trial recommended free naloxone be available nationally. And then in July this year, we saw that happen. I guess what struck me over time is that there's been a great deal of cross-sector cooperation and support. And I'd note the National Naloxone Reference Group that's chaired by my colleague Paul Dietz has been central in that over the last number of years. We've really got on with things. We've piloted and evaluated and seen those things diffuse to other jurisdictions, which has been fantastic. There's been expansion into new settings in terms of in pharmacy, in terms of pain patients and so on. And of course, this work with police that we're going to be talking about today, as well as leave behind projects that are being run out of ambulance services. And the theme has been that science has been addressing the barriers and doing evaluations of these new expansions of take-home naloxone availability. And that's really what we're going to be talking about today. So that's all from me. Thanks for your time.
Thanks so much for that, Simon. Now I'd like to hand it over to Seraina for her discussion of the WA Police Force program.
Hello, everyone. So today I'm going to present the main findings of the evaluation of the WA Police Force Naloxone pilot. This project was funded by the Mental Health Commission of Western Australia, and I would like to acknowledge Grace O, who used to work at the Mental Health Commission and who was the Mental Health Commission Naloxone project lead who was in charge of this project. She provided face-to-face naloxone training to the WA Police Force during the pilot, alongside with Mark Lowery and Rebecca Kraft. I would also like to acknowledge my colleague, Professor Simon Lenton from NDRI, who was in charge of the evaluation of this project, and Lucas Wright from the WA Police Force. So today I'm first going to give you some background about naloxone, then I'll talk about the evaluation of the naloxone pilot itself. and then show you some quantitative and qualitative data. And I'm also going to use some slides that were kindly provided to us by Grace Ho during this presentation, so I'd like to thank her for that. So today I'm speaking to you from the land of the Whadjuk Noongar people, and I would like to pay my respects to elder, past, present, and future, and extend my respects to all the traditional owners of the lands where you are joining us from today, and pay respects to any First Nations people who may be online. So first of all, I just want to make sure that you're all familiar with naloxone. I'm pretty sure you all are, but just in case. So what is naloxone? So naloxone is a drug that can temporarily reverse opioid overdose. Naloxone has a stronger affinity to the opioid receptors than opioid themselves. So it basically knocks the opioids off the receptors for about half an hour to 90 minutes. This allows the person to breathe again and reverse the overdose with minimal side effects. Research shows that it's safe, it has minimal to no side effects in the absence of opioids, it cannot be abused, and it does not increase risk-taking, and it has been used in the US since 1971. So the naloxone devices that are currently being used by the WA Police Force are intranasal devices. One box contains 2 single-dose containers of 1.8 milligram of naloxone. It's a device which is very simple to use. So you basically just need to insert the nozzle into one nostril and then press on the plunger. So opioid overdose rates have been increasing steadily in the last 10 years and remain a public health concern around the world. In 2021, the most common drug type associated with unintentional drug-induced death in Australia were due to opioids, which accounted for 46% of unintentional drug-induced fatalities. Unintentional deaths involving opioids have almost doubled in Australia, from 413 in 2001 to 765 in 2021. So why should police officers carry naloxone? And I would like to thank Grace Ho for providing us with this great slide. So there's a few very good reasons why police officers should carry naloxone. So studies have shown, for example, that police officers are often the first emergency responders and sometimes even the only ones on the scene of an opioid overdose. So it's definitely a game changer if they're able to administer naloxone to someone who had an overdose. So carrying naloxone enables to reduce overdose harms and deaths and save lives. And police officers can also use naloxone when attending welfare checks, for example, and provide early naloxone intervention to support paramedics, as they often arrive before the paramedics on the scene of an opioid overdose. So carrying naloxone can also reduce the impacts of trauma, and this has multiple layers. Firstly, preventing overdose in the community of someone who is loved, and supporting a trauma-informed workforce. The police officers who have the unenviable job of knocking on mom and dad's door, who can now respond to overdose with naloxone to not lose people, to help save a life. And they can also provide a message of, we are here to help you, help the community, and therefore build stronger relationship with the community. The Mental Health Commission talked to police officers about community engagement during their training. So once the paramedics arrive on scene, police can talk to bystanders, family members, friends, or other witnesses present on the scene of an overdose to share their knowledge and provide a message such as, we just used naloxone, let me tell you where and how you can get it in case you need it or you need it for someone else. So as I've just said, police officers are often the first emergency responders and sometimes even the only one on the scene of an opioid overdose. But the issue is that, unfortunately, they might not necessarily be equipped with naloxone, even though carrying naloxone enables to significantly reduce overdose harms and deaths while providing early naloxone intervention. So naloxone enables to buy time while waiting for the paramedics, and this can definitely make a big difference. For example, Rando and colleagues in the US found that naloxone deaths decreased by an overall average of 13.4 fatalities each quarter after the implementation of a naloxone distribution program. And another study conducted among police officers in the US also found that naloxone training was particularly effective in increasing competency in administering naloxone, as well as reducing concerns about administering it. So following the training, 81% of the sample responded that they had enough information now about how to manage an overdose, which was only the case for 10% of participants before the trainings. So this is quite a big difference. And similarly, 93% of participants reported that they were able to effectively deal with an overdose now, while it was only the case for 32% of the sample before the training. So it's as well quite a big difference. Some studies also suggest that emergency responders, including police officers, but also emergency medical services like paramedics and firefighters, have higher risk compensation beliefs than other health and social providers, such as social workers, for example. So what are risk compensation beliefs? So risk compensation beliefs have been described in the literature as the belief that access to naloxone will encourage drug use, as well as reduce the likelihood of seeking treatment, even though this is not true. So for example, a study by Murphy and colleagues in 2020 found that 83% of police officers believe that naloxone might encourage drug use, while 43% believe that there should be a limit on how often someone who overdoses receives naloxone due to these risk compensation beliefs. However, the good news is that naloxone training can significantly reduce these common beliefs, which are not supported by any evidence, as I said before. For example, a recent study conducted by Vinograd in 2020 found that police officers had fewer concerns, fewer negative attitudes, and less endorsement of risk compensation beliefs after receiving naloxone training. And another study by Smasher and colleagues found that even though police officers had some concern about using naloxone initially, 60% strongly agreed that the benefits of the naloxone programs outweigh the risks. The perception of police officers in the community may also be improved by expanding access to naloxone, as it conveys the message that they are here to help the community and save lives. For example, it has been shown that police officers who have been trained in naloxone administration can also provide consumers with information about local drug treatment options, for example, and build positive interactions with community members, as I've said before. Some people in the community might have negative perception about policing, even though their role is to help and protect the community. For example, a study conducted by Wagner in the US reported that about 20% of consumers who were administered naloxone by police officers sought treatment after a police officer referral. So now let's talk about the pilot. So the pilot was publicly launched on the 1st of July 2021 and ran until the 30th of July 2022. During this period of time, 447 police officers were trained by the Mental Health Commission in administering naloxone. So the Mental Health Commission ran 40 training sessions across 14 metro and 2 regional locations in WA. And the team trains were very diverse and included police officers from, for example, the Watch House, the Bi Squad. The WA Police Force became the first police officers in the southern hemisphere to carry naloxone. The day the pilot was launched, there was lots of information on social media, radio, local, and even international newspaper. And all of it was very well received by consumers, but by police officers themselves. So the Mental Health Commission also told us, for example, that they had provided naloxone training to a team in the morning, and a few hours later in the afternoon, the same team was called to attend an opioid overdose. And the police officers went there. They were the first on the scene. They administered naloxone while waiting for their paramedics to arrive and saved their lives. So this was pretty amazing. In order to assess the effectiveness of the pilots, the 447 police officers who had received naloxone training were requested to complete a pre- and post-questionnaire before the beginning of the training and at the end of the training as well. So the questionnaires included, for example, questions about the signs and symptoms of an opioid overdose, what needs to be done when witnessing an opioid overdose. 272 participants completed the pre- and post-questionnaires. They were also requested to complete an online follow-up survey 3 to 6 months after the completion of the training, which included, for example, questions about the quality of the training itself, knowledge retention, access, and availability of naloxone. And 117 participants completed the survey. And participants who had administered naloxone since receiving the training were then invited to complete a follow-up interview over the phone, and 8 police officers agreed to be interviewed over the phone. So now I'm just going to focus on the pre- and post questionnaires that the participants completed just before the training and at the end of the training session. Participants' socio-demographic status was not collected when completing the pre and post questionnaire, as these questionnaires were provided to the police officers by the Mental Health Commission and were mainly assessing knowledge retention. But overall, there was increased knowledge after the training in terms of recognizing the signs and symptoms of an opioid overdose, as you can see on the table. And I'm just going to give you a few seconds to have a proper look at this table. And there was also increased knowledge after the training in terms of recognizing the signs, which increased the risk of an opioid overdose. And again, I'm just going to give you a few seconds to have a look at the table. There was also an increase in the number of participants who said that they would administer naloxone after the completion of the training. For example, 66% of participants said that yes, they would administer naloxone before the training, and this went up to 99% after the training, which is very positive. And there was also an increase in the number of participants who felt more confident to respond to an opioid overdose after having received naloxone training, as only 35% of respondents initially said that they were either confident or very confident to respond to an opioid overdose before the training, while 97% of participants responded that they were either confident or very confident to respond to an opioid overdose after the training, which is great as well. So now I'm going to focus on the follow-up online survey that the participants completed 3 to 6 months after the completion of the training. So who were the 117 police officers who completed the online follow-up survey? So they had a mean age of 38 years, ranging from 19 to 63 years. The majority of them were males with a length of service of 134 months, so approximately 11 years of service. As you can see on the table, 94% of police officers thought that the quality of the training was excellent or good. 90% of them felt that their competence to administer naloxone increased after the training. And 100% completely agreed that they would now be able to administer naloxone in the case of an opioid overdose, which is very positive again. In terms of the attitudes toward naloxone, 92% of police officers completely agreed that everyone at risk of witnessing an opioid overdose should be given naloxone. 97% completely agreed that it was reassuring to have access to naloxone. And 98% of police officers completely agreed that police officers should have access to naloxone. 100% also completely agreed that it would call an ambulance and commence first aid if someone overdoses. And 20% of respondents witnessed an opioid overdose since the training. And when we asked them how many times they had resuscitated someone using naloxone since receiving their training, 44% of police officers responded once, 17% responded twice, and 30% responded none, which means that naloxone might have been deployed by their colleagues or the paramedics. And lastly, I'm going to share with you some insightful polls that were gathered during our qualitative phone interviews. And as I said before, 8 participants completed the phone interviews. So in terms of the qualitative interviews, several participants reported that they were grateful for the opportunity to be part of the pilots. And some participants also highlighted that being able to do something good in a profession that often involves negativity in the community and lack of positive feelings was actually very positive. So I'm just going to give you some time again to read this quote. This is another example of a police officer who reported positive feelings after helping someone out, but who highlighted as well that the feelings were even greater when you appear to have saved someone's lives. And again, I'm going to give you a few seconds to read this quote. Others also mentioned that naloxone gave them confidence that it would work and would be effective in saving someone's lives, so that they could basically trust the process and trust the device. And others also mentioned that it gave them a sense of confidence to go ahead, as there would be minimal harm to administer naloxone to someone who didn't need it, for example, someone who didn't use opioids. And several participants also reported that naloxone enabled them to provide early intervention by buying time before St. John ambulance took over. So to sum up, our findings show that the training was very well received by police officers. It seems to be effective in increasing police officers' knowledge associated with drug overdose and improve their capacity to recognize and manage opioid overdoses. So these results are in line with prior research, which suggests that expanding naloxone access to police officers enables to significantly reduce the risk of opioid overdose fatalities in the community. And to conclude, carriage of naloxone by police officers in Australia is feasible, effective, and may save lives. It should serve as an example for other jurisdictions to roll out similar program, and it's definitely a game changer, not only for the community, but for the police officers themselves. And the good news is that following the pilot, all police officers in WA will now be carrying naloxone, as announced on the 14th of August by Police Minister Paul Papalia and Health Minister Amber-Jade Sanderson. Thank you very much for your attention today.
Seraina, thanks so much. That was wonderful, and those quotes to see were sort of inspiring, actually. So now Lucas Ride is with us to give a complimentary perspective from inside the Western Australia Police Force. Just a quick reminder before Lucas starts speaking, that you can post questions in the Q&A box, as we will get to those questions following Lucas's comments. So Lucas, the mic is yours.
Good afternoon, everyone. Yes, I've been involved with the project before it started and ongoing now. I just want to acknowledge my colleague, Inspector Andrea Smith, who was heavily involved during the development phase of the project. So yeah, prior to this trial, data on overdose attendances by police was pretty limited. So we didn't have a picture of how many times we're first on scene to an overdose. And I think a lot of my colleagues from other jurisdictions would be in a similar boat. It's just not a data field that's captured. So it's difficult to forecast how many we would be attending with this trial. And also being the first law enforcement agency in the Southern Hemisphere doing it, we didn't have any comparable data to see how often it would be used. But in the trial now, up until August this year, naloxone has been administered on 44 occasions, so roughly 2 times a month, and that's only within the trial areas. So it's been used a lot more than was expected initially, which shows the importance of the initiative moving forwards. During the trial phase, in terms of interest from other trials, well, non-trial sites, there was significant demand. Initially, we started out with 4 trial sites, but that soon expanded based on this demand. And that kind of deviates a little bit from overseas law enforcement experiences, where there was a bit more reluctance to be involved with naloxone. So the demand, yeah, that's been absolutely amazing. And since we've gone to the online trial, when that was made available to officers, I think within the first few weeks, at least 50% of 5,000 odd officers had done the training. So you could see the interest was there, and word had spread from officers that were in those trial sites. And in terms of some of the information captured in the slides there, there was a view perhaps that there would be a reluctance to administer naloxone, but officers already provide first aid training, first aid to people, and the addition of naloxone as a step in the standard first aid response was simple and effective. And I think a big benefit was the availability of the nasal spray. Reduces a lot of reluctance. People would be less willing to use the injectable forms of naloxone, whereas this is quick, easy, non-invasive, and very effective. During the trial period, there weren't very many challenges faced. There were around the training, because it was face-to-face. Officers might be called out to jobs, so training numbers were low in certain sessions. So there was a lot more training sessions than that needed to be undertaken. And also officers get posted to different areas outside of trial sites, and you've got new officers coming in that needed the training. But this, with the expansion to operational officers in operational areas, the training's moved to an online version, pretty much based exactly on the face-to-face one, but it enables officers to do it in their own time, and also increase the numbers, because it just wouldn't be feasible to train face-to-face, 5,000-6,000 officers. And like I said, the demand for that training has been very high as well. Feedback from St John's and other agencies and the community has been very positive. Law enforcement generally focuses on supply reduction, but this is one of the positive initiatives in the harm minimization and demand reduction sphere. So sort of complements the work we do at the higher drug dealer sort of level. And another one that was also sort of touched on a little bit for Seraina is actually the benefits to officers themselves. Attending any death is traumatic for the officer. Not being able to do something to potentially help the person who's overdosed can also be traumatic. Having this simple tool can buy that time for the paramedics to arrive, take over, and get the person the help that they need. So you're preventing all of that trauma for the officer themselves, but also the bystanders, the friends, families, and loved ones. And that also boosts relationships within the community, that we're doing positive things to the community. Another thing that is sort of separate to helping the community where there's overdosed is also security for fellow officers. Officers come into contact with drugs quite often in their day-to-day work, and accidental exposure to opioids, particularly the potent ones like your carfentanil, is a risk. And if you look on the internet, you'll see quite a few videos from the US of police officers being exposed to opioids and overdosing, and the ones that had access to naloxone survived. And it's just an amazing life-saving tool. And there was one recently, I think in Florida, there was a $1 note with some fentanyl on it. Officer accidentally inhaled it, handling it and overdosed, but they had naloxone and she survived. So having that available during your line of work is a benefit, knowing that some of your colleagues could help you if you were accidentally overdosed. And fortunately, to date, none of our officers have been in that position, but you know, the risk, or the chance of it happening is low, but the risk, if it does happen, can be severe. So it provides that reassurance to have it available. And I suppose from here, I'll just answer some questions if they arise from that. Thank you.
Thanks so much, Lucas, and thanks to Seraina and Simon as well. We do have a growing list of questions coming from the audience. And I guess I'll start with just a couple of sort of clarifying questions that came in, and these might be for you, Seraina, or possibly Lucas. But someone just wanted to clarify how many times the police administered naloxone. I believe, Lucas, you said 44. And also whether there were any fatalities among treated patients.
Well, in terms of the fatality, I don't have that data. I'm not aware of any, but that's not to say it hasn't occurred. Generally, it would be handed over to the paramedics or the doctors at the hospital, so we may not have that information.
And also, I guess I'll just add to that. Were there any particular guidelines on aftercare in the immediate aftermath of dispensing naloxone? And, you know, were they, to the extent those guidelines existed, did they seem to be viable in practice?
Yeah, so in the training, it captured, you know, recognizing the signs of overdose, what to do, the first aid response, and post naloxone administration. So it had all the day received the training and all of the steps on reassuring the person, you know, recovery position and all of those type of things. And then the ambulance would also come and take over from there. But they had all the training to deal with that. So it's, yeah, worked well.
A couple other practical questions about the, you know, the implementation of the program. One was about, you know, the kits that were given out and, you know, in the steps necessary to ensure the integrity of naloxone as a drug. So in particular, things like making sure it doesn't heat up in the famous Western Australia heat, and, you know, and anything else that was sort of, you know, trained or provided with the kits.
Yeah, I mean, generally they're kept within the first aid kit. I mean, Simon might be able to talk to this more, but naloxone is a very stable drug over a long period of time, and in different temperatures. There's been some studies in the States with law enforcement and testing their naloxone, and it was still highly effective many, many years later. So generally it's in the first aid kits for your bike teams, and that it will be in their first aid kits because they're out and about, and it's available back at the station so the cars can bring it out if it's needed within that district.
Great.
Yeah, I mean, the existing evidence suggests it's incredibly robust at a range of temperatures. As Lucas has said, most of the work was done prior to the intranasal form, but there's no evidence that suggests that it becomes non-viable with a range of temperatures or over time. I think it was tested up to 12 years and it was still viable. And the other thing about them, and Lucas might want to comment on this, is that, you know, they're incredibly small and incredibly light, so they don't add a great deal to the bunch of stuff that police officers carry around with them anyway. But Lucas, you might want to address that issue.
Yeah, it hasn't been an issue during the trial, generally because it is in the first aid kit, easily accessible when they rock up. It's only for the bike teams. It is very light, it's small, easy to carry. So we haven't had any issues raised with that.
And is it one per officer or you know, so like 2 boxes each, you know, 2 boxes for a team, for instance, or is it like per car or per team?
It's per car, but also, yeah, with the smaller teams, they'll have the 2 each. And so, you know, if you've got a team of 5 people, that's 10 units, which is more than enough until help comes.
Right. Thanks for that. Another question about sort of the practicalities of it. Someone mentioned that that there are instances, and I've seen this in some of the literature on police and naloxone as well, instances where people may become a bit agitated, which is, of course, the result of precipitated withdrawal that can occur when naloxone is administered. And so was there any experience with this and any training given on how to handle it?
Well, yeah, within the training, it does have that post-naloxone, how to handle post-naloxone with the person and explaining things. And we're already trained in responding to anything like that. We had some people that were upset that we'd ruined the high and things like that, but no really aggressive responses that I'm aware of. And some people I know were very grateful that we had done the naloxone, and I think that person had it twice before by police, so they knew that we're trying to help them and not ruin their day. So yeah, no, nothing that I'm aware of.
Great.
And I can just add that some of the stuff that's online, the stories have been around for a long time, was when people are administered intravenous naloxone, prior to even intramuscular naloxone, and the intranasal form does come on pretty quickly, but there's less reports about those kind of horror stories of people being whacked into opioid withdrawal and becoming extremely aggressive. That's much rarer in the use in this setting.
Thank you. A question about the training in terms of first, was it delivered by NDRI, or who actually delivered the training, and also in terms of the content, was sort of anti-stigma training part of that content, of the training content, and finally, related to that, was there any involvement of people who use drugs in the development of the training content?
Well, the training content was delivered and developed by the Mental Health Commission, who provide the training to a whole range of other government and non-government agencies. So it covered the recognising signs, responding to it, things that increase risk of overdose. And they would, in their sort of Q&A, may have some questions around stigma, but it's not, it's more, given the time limitations, you got to train 6,000 people, taking them off the job to do that. It's mainly focused on those three things: recognizing it, responding to it, what to do afterwards, and then our policy and procedures about recording naloxone use and things like that.
Mm-hmm.
But sorry, there was a section as well where at the beginning of the training, they made sure to address some concerns that the police officers might have had in terms of stigma and discrimination, for example. And they talked about mental health issues as well, like why do people actually use drugs? So they don't wake up one day and decide to inject drugs. So there was a section about mental health issue as well. And
also sort of related to that, there were some of the quotes in your presentation, Seraina, showed, the impact on the police officer and the way that they felt so sort of inspired and confident after helping save somebody's life. So that, can help improve relations with the community. I'm also wondering about the sort of harm reduction in AOD sectors, and whether this program resulted in any sort of change in dynamics between the police and harm reduction organizations, and sort of also how harm reduction groups can help support police in the provision of this program.
Simon, maybe would you like to comment on that?
Yeah, it's not something that was addressed specifically in this evaluation, but I can say that we've had a opioid overdose strategy group that's been meeting for, I think it's 30 years now, between a whole lot of stakeholders, Mental Health Commission, police, justice, drug user organisation, researchers, a whole bunch of us that have been looking at this issue as it evolves over time, and we have good relationships between, peer-based harm reduction WA and the police and a whole lot of other stakeholders, and so it's fitted within that broader context of good relationships between people over time. And we don't have any data on. I don't have any data on what you've talked about, but I do know that I've heard anecdotally from peer-based harm reduction that that members of their organisation, drug consumers, have noted and reported back to them that they saw police administering naloxone, that it was great to see police doing that. So informally, the word's out there that this is going on, and there's been no indications of anyone being unhappy about it. In fact, quite the contrary. But Lucas might have something from his perspective.
Yeah, I mean, I suppose just adding to that, with the overdose strategy group, we already have very good relationships with community organisations like peer harm reduction. So it's just another thing that, helps strengthen those bonds and those relationships. But we've been fortunate with this overdose strategy group. It's been very effective over all these years.
Thanks very much. So now to move to sort of a much broader issue, which is really, and I guess, I address this to any of you, but particularly Lucas, what are some of the main messages that the Western Australia Police Force would make to other police forces across Australia that are considering distributing naloxone?
I suppose, during this trial and post the trial, I've been contacted by most jurisdictions that are looking at this. And they're all very keen to learn from our experience. We've done some teleconferences with them, but it's all been very positive. It's just some of the policies, procedures, that side of thing that we've been helping them with as well. But no, it's been really well received, and I think you'll see in time other jurisdictions adopting a similar approach across the country.
Great. And Simon or Seraina, have you been contacted by other police forces as well? Or had any contact?
Yeah, we've had a couple of requests come through to us that we've passed on to Lucas. The bulletin based on this project is available on our website, and people have been downloading it and so on, which is good to see.
Great. And a funding question: was the funding for this just through the standard, police department budget, or was it through the Commonwealth Naloxone program? Where did it come from?
So the WA Mental Health Commission funded for police to be involved in the project.
And is that how it will work in the ongoing distribution as well?
Yeah, Mental Health Commission will be supplying it for us.
Mm-hmm. Great. And someone had a question about whether the provision of naloxone was sufficient in any area to actually affect, the number of overdose deaths. I mean, it's hard to know what the counterfactual is, of course, but whether, I guess you could think of it as whether there were any sort of like real concrete effects you could see in any particular area where police were doing the trial.
It's low numbers of naloxone administrations, and any deaths, coronial inquiries take years, so that data wouldn't be available. But I mean, we do know that the rate of opioid deaths in WA is quite high, yet the use is low relative to some other jurisdictions, just based on the wastewater. So naloxone is going to be a positive thing in hopefully reducing that rate. So in time, maybe we'll get some data that way, but at the moment, the numbers are so low, there's nothing concrete that we can comment on.
And now, just another practical question. Are police able to provide naloxone to community members or just administer it themselves? I assume the latter, but just to be clear.
Yeah, it's just to administer, but they can obviously refer them to say, hey, it's available at your chemist or at these services, but we're not supplying it. It's more administrative.
And anecdotally, did you find that community members were asking about police about naloxone? in terms of where they can get it?
I mean, the messaging from organizations like Peer Harm Reduction about naloxone is very good. So a lot of bystanders and that are already aware of naloxone and why we're administering it. So I don't have any specific comments on it, but yeah, a lot of people have that awareness already.
Great.
Sorry, I just want to specify as well that, so as Lucas said, they are not distributing naloxone, but NDRI is currently evaluating a project. And in WA, paramedic ambulance officers and volunteer ambulance officers are allowed to dispense naloxone to the general public when they attend an opioid overdose scene. So if, like, for example, there is a friend who is present on the scene of an overdose, they can explain to that person how to use naloxone for future overdose events.
Oh, great.
And so just generally, this is one intervention in a broad suite of things that are happening, not just in WA, obviously, but across the country. And of course, the rollout of free naloxone has been incredibly important in that, but there's a whole lot of different strategies that are going on. And, this is one part of that and fits into the broader dissemination of naloxone and broader education about its use.
Great. I have a question, which is, and I'm not sure whether you can tease any of this out of the data, Seraina or Lucas, whether you can respond, but I'm wondering whether, and this goes a little bit to things I've seen in the US context in particular, because in the US there are over, I think, 2,500 at last count agencies that where police carry naloxone. Of course, that's out of like 18,000 police agencies, but still, it's a lot. And one thing that's come up is generational differences within the police force. Whether, there are some people maybe older versus younger, that can play out different ways in terms of confidence, but some of these things you might see either generational differences or perhaps geographic distances or differences with people, out in regional versus people in the metro area. So did you see any differences like that? And are there any ways they can be addressed?
Yeah, no, I haven't seen any of those type of things. And I mean, the last one on regional and metro, we move around offices everywhere. So they would have been in both. And ages, I haven't noticed any differences either, but that there isn't specific data on that.
Okay.
Seraina, just prompt, we looked at that within the data set? I can't remember.
No, we haven't done that WA Police Force yet.
Yeah. And the other thing is that, some of those, hypotheses you might have about metro versus rural or younger versus older can actually go the other way, and a lot of people in the rural area were as keen as mustard to get access to this as well. So, it works both ways.
Absolutely. Right. I guess we're coming to the close of our session here, but I'm just wondering if there are any sort of final messages, either about things, sort of next steps within Western Australia Police Force and things that, you're working on improving or in terms of expanding, or some final thoughts on what this pilot and what this rollout means for police in the rest of Australia. So I'll start with you, Lucas, actually.
Yeah, well, I mean, this project has been very rewarding, and I only see an upside with it. I don't think there's any negatives with it. I think other law enforcement jurisdictions will probably follow suit. We're rolling it out to all operational areas in operational officers. So basically anyone that would come into contact with the public. And yeah, having that knowledge provides reassurance to them that they can do something positive. And yeah, I only see positive things from here. So we're just rolling it out. The training's going along well. So yeah, it's getting there. Great.
Seraina, anything in your observation that you would like to say to the audience or to police forces in other jurisdictions?
Yeah, I would strongly encourage all the other jurisdictions to get along with it, because it's definitely a game changer, not only for the people who are victims of an opioid overdose themselves, but also for police officers. So it's an amazing tool and everyone should have it.
Thanks. And Simon, that leaves you with sort of the last word here.
Yeah, these guys have said it. This is a fantastic collaborative intervention between police, the mental health service, and the drug using community, and it really is a game changer. It really puts people on the same side, which I think is super important, and to be saving lives and to have lives saved in this context is a real game changer, as Seraina said. And I want to thank everyone for their attendance, and we look forward to similar programs operating in other jurisdictions. We'd be happy to help out however we can. Thanks for organising it.
Yeah. Right. Thank you so much. And yeah, so first of all, thanks to our panelists for a great discussion about what truly is a life-saving intervention and somewhat of a miraculous drug. And so thanks also to the audience for attending and asking some very pertinent questions. If you want to know more in general about the issue of overdose in Australia, you can visit the Penington Institute website and obtain a copy of Australia's annual overdose report, the current version of which we released just a few weeks ago, and we'll have mind-boggling detail on the issue of overdose in Australia. And as Simon and Seraina mentioned, you can also go to the NDRI website and get a copy of the overview of the evaluation of the pilot Naloxone rollout in WA. And thanks also to our team here at Penington behind the scenes for running the webinar. And have a great week, everyone. Thanks so much.